So hi, I'm Linda. Some of you know me, some of you don't. I'm an education coordinator for the respiratory department. I've taught for years. I've been a therapist since 1981. I don't want to know if you weren't born yet. Please just don't mention it. I'm not thinking about it. This one or this one? Okay, is that better? Oh, all right. Anyway, so I've taught mechanical ventilation at the School for Respiratory Therapy for years and years and years and years. So it's like my favorite topic. So I said, sure, I'll come talk about this. All right. Isn't that nice? Great slide. Okay, here we go. Okay. So because I don't know where everybody is in their knowledge of mechanical ventilation, I'm just going to go through the basics here. Just a lot with terminology. Tidal volume. It may be something we set directly or it may be something indirectly set, but it is basically refers to the amount of air the patient takes in and out with each breath. Normal size of it is 5 to 8 mLs per kilo of predicted body weight. So you guys all know if you put the height in on the patient, then the predicted body weight will come right up for you. So we like that because otherwise it's a long equation. But it's also very depressing if you want to ever just put your own height in there and figure it out. I don't recommend doing it. Anyway, the frequency refers to the mechanical rate that's set on the ventilator, and we have that compared to the total respiratory rate. Now, not all vents call it frequency. They might call the set rate down here, it'll say respiratory rate, but over here, you'll see your total respiratory rate show up there, right? So if the patient's breathing over the set rate, then the total rate will be higher, all right? Anyway, so they may not always be the same. So sometimes if you're reading material on it, you might hear the term frequency, and that's what they're referring to, is the set mechanical rate. I'm just going to pause this because I don't really want it to start making noise. All right. Anyway, minute ventilation is just like cardiac output, only it's for the lungs. It's how much you breathe, so the volume you're breathing each breath times the rate that you're doing that, right? Just like cardiac output, 5 to 8 is normal. 5 to 8 is normal for minute ventilation as well. When you guys send a blood gas off, when you guys are sending a blood gas off and you're filling out the blood gas slip, please be sure to note the minute ventilation. Why? Because if I have a CO2 that is 40, which is perfectly normal, and I'm breathing 6 liters per minute, that's great. But if I have a CO2 that's 40 and my minute ventilation is 20, I got serious troubles there. And that is taking me 5 times the amount of normal ventilation to maintain normal CO2. So there's a lot of physiologic issues there. It's important to know how fast that car is going to generate that PO2 or CO2. Similarly, with FiO2, it's always important to know what that relationship is too. Just because we have a PO2 of 100 is great, right? But if it's taking 80% oxygen to get me a PO2 of 100, I got a whole lot of problems going on with gas exchange, right? So it's always something, normal isn't always good. You always got to look at that PF ratio as well. We'll get to that though. Sorry, I just went off. Speaking of FiO2, there we go. You guys all know that's the amount of oxygen we breathe in. Hopefully you all know that room air is 21% and the max that we can do is 100%. That's good. What you may not know, and this is just a helpful tip, yes sir? Mm-hmm. We should be sending like the set rate. We're not sending their actual rate. Total. You want the total rate and the minute ventilation. I actually will put both numbers down, set/total. And that's why, but that's if you put the minute ventilation and it shows up right there. So if I had a rate of 12 and I see that my tidal volume is 450, but I see that my minute ventilation is 15, I'm going to know I'm breathing more than that. So if you have the set rate and the minute ventilation, it conveys enough information that you don't actually have to write the total rate. Okay. But it's important if the patient's breathing over the vent, again. The information on it, you cross it out or you modify it. If it says 12, I'll write 12/total rate 20. You can write it. Now, whether the lab will actually input that information when they put it in, I don't know. It varies. Sometimes they do, sometimes they don't. Sometimes they write venting mask when it says vent. So I've seen some interesting things transfer over from the lab. But the minute ventilation is really the most important one because that'll imply the total rate anyway. So that's this one. I'm sorry, it's this one right there, the blue one here at the bottom. It says MVE. MVE. Okay. Yeah. Okay. So PEEP, that's the amount of pressure that we put in the lungs. It's there. It's also called baseline pressure. So we usually add a little bit of PEEP. Once we intubate somebody, their epiglottis is left out, right? Because the tube is in place. So you lose a little PEEP effect that you would normally have if you have a tube in place. So we put them on at least 5 PEEP, and we call it physiologic PEEP, right? Well, that's what, you may hear that term, but anyway. At least 5 or 6 is usually a good place to start with most people. That's not a lot of PEEP. It's pretty much normal amounts of PEEP. So what it does do, though, is it opens up the lungs a little bit, helps increase alveolar size, gives them a larger area for gas exchange, surface area for gas exchange, improves lung compliance. What does that mean? Well, just like your heart might have a bad ventricle, right, that loses its compliance, your lungs can either be really stiff, or they can be, in the case of COPD or emphysema, overly stretchy, right? So when you're really stiff, we add a little bit of PEEP to open it up and improve lung compliance. If your lung is stiff, it's very hard when you breathe. You're not going to move as much tidal volume with each breath. So we add a little bit of PEEP, and that might make it easier enough for you to start breathing. So I don't know if you guys have worked a lot at ED or if you've ever taken care of somebody with CHF. Sometimes just putting them on a little high flow nasal cannula, which creates a little CPAP effect, is enough to help open up the lungs enough to improve their work of breathing so that they can breathe effectively. I don't need to put them on BiPAP or intubate them short term. So PEEP is a good thing. It generally will improve oxygenation, help it decrease work of breathing, and just kind of help restore resting lung volume. There's a slide a little bit later where I talk about, we have 3 words, and all basically means the same thing. It just kind of depends on how we're ventilating the person, whether we call it EPAP, PEEP, or CPAP. It just all depends. It's basically a baseline pressure. They all mean baseline pressure. We just use terminology differently to keep our jobs. That's not true. We use the terminology differently because there's different degrees of ventilation, but I'll explain that to you later. All right, another setting on the ventilator is your inspiratory time. We set that. It's one of those important things that we set. Normal value for it is about 0.6 to 1.2. If it's less than 0.6 for an adult, this is all adult stuff. Okay, I don't do kids. So these numbers would be way different for children, infants in particular. Less than that, you're not really going to have enough time for adequate gas exchange. More than that, it's just going to be uncomfortable for the patient. We try to breathe in for 1.2 seconds. That's not going to be comfortable for anybody. We hardly use it that long of a time. Typically, we get on the shorter end more than the longer end. But anyway. All right, so modes of ventilation. You'll hear all kinds of descriptions. I like to keep it really simple. All right, assist control. There is a control mode, but nobody uses it anymore. There's no ventilator out there that will allow you to lock the patient out of it, which is what a control mode would do. I'd actually turn it off and not let the patient trigger the machine. We wouldn't do that to anybody. We don't anymore. So ignore anything you read about control ventilation. Assist control, you're going to have a set rate and a set other value, whether it's a set tidal volume when I'm in volume control, or a set pressure level if I'm in pressure control, or a set volume limit if I'm in PRVC. I'm targeting that volume, and I'm adjusting the pressure up and down to maintain that volume. The main thing is I have a set rate and something else that designs the mechanical breath. If the patient wants to breathe again, he gets that mechanical breath. There's no spontaneous breathing. There's no pressure support in between the breaths. Every breath that he initiates will be the same mechanical breath that he gets. Same volume size, the same pressure level, same tidal volume, same whatever. It just kind of depends on which way I'm choosing to give assist control ventilation. Does that make sense? The main thing is I have a set rate, the patient can breathe over it. But every breath is mechanical, whatever that's set, however it's designed. It's like, am I wearing plaid or am I wearing stripes? Okay, it doesn't matter how we give the breath. Okay. All right, and no spontaneous breathing. So the downside is every breath is the same. That may or may not be comfortable for the patient, but if they're on assist control mode, hopefully they're properly sedated. All right. Anyway, therapists, different doctors have different beliefs about what mode is better. No mode is better. No studies have ever shown that any mode of ventilation is superior to another in general. I can do assist control ventilation using pressure control or volume control or PRVC. It just kind of depends on my personal preference. I can make the breaths basically look the same if I go from volume control to pressure control because I tweak all my other knobs. So it really doesn't matter. There is none that is superior. There are maybe reasons I might want to use one over another, but generally speaking, overall outcomes, it just doesn't matter. You can ventilate them effectively as long as you know what you're doing with that mode that you've chosen to work with. That's a little citation that will basically say all of that. Probably better. All right, so modes of ventilation. In volume control ventilation, which is what I'm just seeing. Oh, I forgot I have an air here. Old days. Volume control was only done with this flow pattern, which is really uncomfortable. You go from nothing to whatever level I've got set, 40, 50, 60, whatever, maintains that level until the tidal volume delivery is done, and then the breath ends, and that's all great, okay? We don't like this one. Nobody likes it. The patients hate it. They're very uncomfortable with it. This one is, it hits a higher float first because people are air hungry. They want that flow right away. They don't want to wait for it for the whole time. They want to just get it. And then it tapers down to whatever point, and I can set this point from anywhere. I can have it taper all the way down to baseline, or I could have it taper down 75%, or I could have it taper down 50%, or 25%, which is what I'm looking at here. That all just kind of depends on how I taper it, determines how quickly the tidal volume is delivered. So I can set that appropriately for the patient so that he's comfortable. It's really something I would do for comfort. And again, better distribution of the tidal volume. So if I get the flow fast here, then most of the tidal volume is being delivered early in the breath, so you have better time for gas exchange. So whether if I'm doing volume ventilation, I would like to choose that option, and we pretty much do. I just in-serviced all the MCCS docs, and we went over all of this, and they all know this is the better one to do. Unfortunately, our vent always defaults to the square one, but anyway, we can change it. It's easy enough to do. And this just kind of shows differences, I'm going to eat this thing, in how the pressure curve looks. And I'm not going to get into all that because that's just more than you need to know. Okay. In a pressure mode, my flow curve looks like this. It's also a deceleration pattern where I hit the flow first and then it tapers it all off. And it may or may not taper down to the baseline. It kind of depends on the patient's lung compliance and airway resistance and settings and eye time and rate. It depends on lots of different factors how it will actually look. But it does give you generally the benefits of volume delivery earlier in the breath. And it's going, what it does, okay, here we go. You can see the picture here, all right? So this is my pressure level. The flow goes in to hit that pressure level, and then it tapers off, maintaining that pressure level until my inspiratory time that I've set is elapsed. What does that all mean? Well, it determines how much volume I'm going to get delivered in there. If I want to change how much volume I get, I have to change my eye time, or I have to change my pressure level, things like that. So. But it's a decelerating pattern, and the main thing to take home with that is the decelerating pattern, whether it's a volume ventilation or a pressure mode. It's the best one for gas distribution and gas exchange in the lungs. Does that make sense? Okay, I know some of this is way more than you want to know, but you just need to know it all. All right, so assist control mode. That's a great mode. There's a mode on here called SIMV, which I'm not going to bother to talk about. I don't think you guys use it in neuroscience. The only place it really has a role is in PACU, post-op, if you just want to, if somebody's recovering from anesthesia, okay, you would put it on there and give them some pressure support, and when they start breathing regularly on their own, you take the SIMV off, and you just leave them on pressure support. So it was the way we ventilate people for the longest time because we didn't have a lot of choices before. But now, I mean, pressure support's been around since '85, and we've gradually learned how to use it correctly, so SIMV really doesn't have a role anymore. Now, some physicians, none of them here, firmly believe in it. So if you go to another institution, I can't help what they practice. If they use SIMV all the time, I'm sorry. Okay, it's actually not a great mode because it actually shows if you have a pretty high work of breathing for the patient because they're getting two different breath types. They don't really know what to expect, right? Sometimes they're getting this mechanical breath. Then in between, they can do what they want. But then that mechanical breath comes in, and they're like, what the heck was that? So it's just not real comfortable for them, right? Anyway, so that's why we use pressure support. Pressure support. Is the patient has to be breathing, has to have an intact drive to breathe. If he does not initiate the breath, nothing happens until the apnea phase kicks in, and we'll talk about that in a little bit later. But how do I know what tidal volume I'm going to get? So I set a pressure level, and if the patient takes a breath, he gets a breath support up to that pressure level, and then it kind of tapers down. And the tidal volume I get depends on how much of an effort he makes, the pressure setting that I've got, which makes sense. What's going on in his lungs? How much airway resistance does he have? What's his lung compliance? What is his chest wall impedance? Does he have a very tight abdomen? Maybe he's got abdominal compartment syndrome. Maybe not so much in your units, but in other units. So it's a good mode. If they get tired on it though, the respiratory rate starts to climb, the tidal volumes will start to drop, and they won't look as comfortable, so you may have to switch them back to assist control. But it is a good mode. It usually uses the diaphragm a little differently. It uses the posterior aspect of the diaphragm, so it does help in delivery and how the flow gets transferred through the lungs, which is a good benefit of it. So it's always a little bit of exercise for the lungs if you want to think of it that way. Another option to pressure support is called volume support. And volume support is like pressure support, only I have a tidal volume goal that I want to keep my tidal volume around 300. So the pressure support will go up or down to keep my tidal volume where I want it. So it's not a weaning mode. I can't assess somebody for readiness to wean using volume support because it's going to maintain my tidal volumes. I would use that one more if I just wanted to exercise somebody who I know wasn't coming off the vent yet, but he can do some breathing on his own, but I don't want to over fatigue the muscles. So I might use volume support in that case. Never in a spontaneous breathing trial because I would never really know how the patient could spontaneously breathe if it was always adjusting for him. So the one that you're going to be most comfortable with is your pressure support mode. But they both basically do the same thing. All right, so I kind of went into a lot of this on pressure support, but I think you guys use that mode a lot. Your patients are on a lot of pressure support, as they should be, because sometimes they just want to do what they want to do, and the best mode that will meet their demands is pressure support. The other ones, that mechanical breath sometimes just gets in their way of what they want, how much flow they want to get. So anyway, so every time the patient takes a breath, it goes up to that pressure level, and then it's going to taper off. All right, so can you guys see the screen okay or not? Yeah? I don't know. Ooh. Tethered, I'm tethered. Yeah? All right. God, where's it? There it is. Yeah, that's a good number. We'll go with that. Okay. Yeah. I know. Okay, so in pressure support, so right now I've got a pressure support of 24 set, which is pretty high, so I'm just going to actually turn that down because that's not a realistic number. We'll set it to 18. All right, so the patient's breathing. All right, so you guys can see what the tidal volume is if you look down here on the screen. Right? So all the way down here, my peak inspiratory pressures, then I've got my mean airway pressure, my PEEP, my total respiratory rate, my FiO2, minute ventilation, and then inspired tidal volume and expired tidal volume. And of course, as always, you can't inhale and exhale at the same time, right? So the inspired number and then the expired number will change to what the inspired was. Okay, you can't look at them at the same time. Because patients, particularly in pressure support, because one breath may be like this, and I might have a 200 breath, or I might do this and get myself almost 600. It really kind of depends on how much effort I'm making as the patient. Same amount of pressure support, but the amount that he gets totally depends on how much effort he puts into it. He pulls in a lot, big volumes. He pulls in just a little teeny bit, he gets little teeny volumes. Same amount of pressure, okay? So that's one of the big variabilities of it. You want to make sure, in general, their tidal volumes should be no less than 5 mLs per kilo. We'll be quiet. I know, high respiratory rate. I'll slow down. All right. Sorry. I have a very personal relationship with my ventilator. I talk to it all the time. Anyhow, all right. So that's kind of the way it looks. You can see how these pictures look a little different. I don't know if you can see that. The way the pressure support works, as I said, it goes up to that pressure level and then again tapers off. So it's got that decelerating pattern, but it tapers down to a point that I set. Okay. So when patients don't look as comfortable on it, there's all kinds of choices that we have as therapists to tweak with these things. Like we can mess with this thing called rise time, which gets the flow in there faster. We can mess with things like this inspiratory cycle off, which is pretty much, it's what ends, it's the point where the flow drops to and then the breath ends and they go into exhalation. So pitching and exhale. I might set that higher if I had a COPD patient, somebody who needs short inspiratory times and lots of time to get all that air out of their lungs. I might set it shorter if I had a trauma patient, young, healthy, relatively healthy trauma patient. It just kind of varies where I would set that. It's adjustable from 1 to 70%. You guys don't need to worry about that, but it is the factor that kind of converts the breath. The other thing I want to talk to you guys about right here is this thing called backup ventilation, because I've seen some interesting things get charted in a spontaneous breathing trial. If the patient stops breathing in pressure support CPAP mode, the ventilator will kick in and start ventilating him at a set rate. Now, if I'm doing a spontaneous breathing trial and my backup rate is set at 15, it will kick in any minute now. It just seems like the longest time. There we go. So it'll tell you right here, no patient effort, right? No patient effort. So I can come in and silence it. Oh, it silences. And now the patient's getting breathing, right? Looks like he's breathing just fine. But do these pictures look like the ones I was just showing you? No, very different. This is very mechanical. That's because these are assist-controlled breaths. The ventilator is doing the breathing. Now, if the vent rate is set high enough that the patient doesn't ever get a drive to breathe, okay, the CO2 is well above 40, and there's no impetus from his head to tell him to take a breath, he can stay on that forever, which totally screws up your spontaneous breathing trial. And I have come in and seen, okay, and up on your monitor, are you apneic? You're not apneic on the monitor because I'm getting 15 breaths a minute from the ventilator, right? Is the patient breathing? No, the patient is not taking any breaths, but he is being respirated, ventilated, right? I've come in and seen alarm silence, no patient effort. Alarm silence, no patient effort. And then alarms again, no patient effort. It'll be silent for 2 minutes. If you don't fix it, it's going to alarm again in 2 minutes. But if you don't fix it, you just come in and silence it every 2 minutes, nothing's happened. The patient is still apneic, right? So this can happen, and it has happened. I've seen it documented. So I have the spontaneous breathing trial going. I come in and I see what I see, and I go, okay, no spontaneous breathing trial is done because I'm in backup ventilation. It tells you right there as well. PS, backup, right? So it tells you on the screen. Also, if you're in pressure support, it looks like this, very suspicious. Nobody ever breathes like this on pressure support. Nice square equal waveform, okay? Just something to be aware of. And now I'm going back into an assist control mode. Any questions on that? No? Okay, good. That's a lot of information. You guys can look at that later. All right. So you'll read I've been doing some of the stuff on Up to Date, looking at some of it, and actually you can't do full ventilatory support in pressure support mode because they count full ventilatory support as the patient doing nothing. I think, no, well, you can set a high pressure support level and have tidal volumes equivalent to 8 mLs per kilo. I don't see how that isn't full ventilatory support, but the patient does have to do a bit of work with pressure support. So if they're prone to getting to desatting, it may not be something they can tolerate. You guys have probably seen that. They're on pressure support until they have fatigued themselves, and then we have to switch them back to an assist control mode. But anyway, it is obviously most commonly used for doing that transition page of when they no longer need full ventilatory support, but they're not quite ready to be extubated, but we want to have them do something so they don't totally atrophy. Again, this is just in case I didn't bring my vent with me, but as I said before, that's kind of what pressure support mode is supposed to look like. Information on the screen again, total respiratory rate, peak pressure that the patient's getting, minute ventilation, and the tidal volumes that they're averaging. So that's good to know as well what their tidal volumes are running. That's probably enough. You guys know, right? The little pink trigger means the patient's triggering the breath. Little pink line here means that's what the patient, pink, or I don't know what color you call that. I call it pink. Some people say it's red, I don't know. If it's here in the flow, then that's the trigger. If we're not flow triggering, which we generally do, you might see it up here in the pressure triggering, so it might be there, but that makes it a little harder for the patient to take a breath. Probably not as likely in your unit. We need to switch that over if they have like a BP fistula or chest tube leak that the chest tube still bubbling, causes that flow that goes out, tends to trigger the vent artificially. All right, CPAP and BiPAP, I know I'll just kind of talk about BiPAP briefly because you guys do use BiPAP, right? Okay. BiPAP we generally do with the V60, but we can do it through this ventilator as well. Right. If you look at this, it's hard to do. If you look at the screen right now, whoops, not right now. Don't look at it right now. Previous mode. You can see it'll say pressure support / CPAP. So which am I in? Am I in pressure support or am I in CPAP? Well, the answer to the question lies down here in this number. If this says anything other than 0, I'm in pressure support. If it says 0, I'm in CPAP. We never use CPAP anymore. We always put somebody on at least 5 of pressure support for a weaning trial. But that would actually be CPAP and not going apneic, so sorry. Does that make sense? Oh, stop. I make it look easy, but it's really not that easy. talk. Anyway, so if it's 0, it's CPAP. But I have a little bit of pressure here. You see that yellow line going across the top? That's the amount of PEEP, CPAP, EPAP, whatever you want to call it. It's baseline pressure that we're keeping in the lungs so that the lungs don't completely collapse at the end of the breath. All right? All right, so BiPAP is like pressure support, only non-invasive. Okay, I set a pressure level that when I'm doing BiPAP, I don't call it pressure support, I call it IPAP. Okay, it's the same thing. IPAP and pressure support are effectively the same thing. Numerically, they're different, but I'm not worried about that. Okay, in IPAP, if I set an IPAP of 10, if I do 5 over 10, okay, I start at 5 and I go up to 10. If I set pressure support of 10, I start at 5 and I go 10 above the 5. So I'm going to go up to 15. So IPAP goes to the specific pressure dial. Pressure support is the change in pressure, the delta P. It's your delta P. All right. So if you're on the V60, your IPAP is what the pressure it's going to go to. If you're on the servo, you set a pressure support setting instead of an IPAP, and it's different. It's going to be 5, whatever the PEEP is, higher than what it would have been on the V60. Okay. Almost doesn't really matter as long as you have a tidal volume goal that you're going to titrate to maintain tidal volume and a respiratory rate. Titrate to maintain tidal volumes greater than 350. Titrate to keep your respiratory rate less than 30. That's really what we want to have on the patient. So it doesn't really matter if I use IPAP or pressure support. It just, as long as you're maintaining tidal volumes and following what the patient's getting and you're not letting him get short of breath. Does that make sense? No? Yes? Maybe? Hopefully. Okay. Good. Just pictures, more pictures. Okay, so if I was doing CPAP, here's your baseline pressure, a little dotted line. And this is inspiration, expiration, because spontaneously we breathe negatively, right? You're just doing it with a little bit of pressure in the lungs, so that's just normal breathing. If I'm on pressure support, then I take a breath in and I go up to this pressure level during inspiration, then down for exhalation, back up to this pressure level. So this is my IPAP setting, this is my EPAP setting, and that's basically how they're different. I'm obviously going to get more tidal volume with this than I get with this, depending on my ventilation. Questions on that? All right, and this is the one I told you about. 3 terms for the same thing, right? CPAP, EPAP, PEEP. So there's a test later. You guys have this? Just kidding, there's no test. Okay. I wanted to give you guys a test. They said no, I couldn't give you a test. I know. Anyway, so I kind of explained all those already, so we'll just skip over that. Bi-level. Do you guys use bi-level in NSIC? If Dr. Who? Dr. Denani. Really? Because it's primarily used for people who have hypoxic respiratory failure. PF ratio is less than 150. You guys good with PF ratio? Do I have to explain that term? No? Okay. That's typically when you're going to think about it. So that isn't normally your guys' issues. But, you know, you have 2 levels of pressure, a P high and a P low, and a T high and a T low. It's basically CPAP, all right? And the patient can breathe over it. So I can demo it real quickly. Yes? No? Yes? Okay. By vent. I can't believe I used bi-level the whole thing. It's actually by vent.